questi 2 giorni non c'è stato freddissimo.
No, no,
Confronto
no.
agli altri giorni.
Ascoltami, ma Giorgia non fa testo, te lo dico
No,
io.
allora io non faccio testo, però arrivo da Roma e da Napoli, quindi capisci che
Vero,
Eh,
vero.
eh,
io sono
abbiate pietà.
siciliano, quindi penso.
Capito?
Sarà
Cioè, io sono
peggio.
pugliese, quindi già di mio, è vero che soffro anche il caldo, quindi la vita è brutta tutto l'anno, però vabbè, comunque, al di là di questo.
Mi sono a maniche corte, quindi
No,
penso.
vabbè, ma voi siete pazzi, voi siete pazzi totali. Cioè, io mi sono cambiata per rispetto nei vostri confronti, nei vostri
Ah.
confronti, perché stavo in una situazione pietosa, pigiama, vestaglia, cioè, infatti sto morendo adesso. Va bene.
Allora. Ok, per adesso stacco
Sì, sì,
il
anche
microfono,
noi.
quindi tra
Vai, vai,
poco. Ok,
tranquillo. Tanto io ho fatto tutto, visto che mi hai messo coorganizzatore, per cui perfetto.
perfetto.
Direi che ci siamo, dai. Mm.
Ok, quindi a tra poco.
Ma sì, guarda,
Vediamo di
secondo me
5
se si
minuti.
collegano ai meno 5 è già un successo.
Va-
Dai, ciao, ciao,
A
ciao.
dopo. Dopo. Ciao.
Io?
Maledetta. Io sto cercando di tornare ad una vita normale.
Alla faccia delle tue sfogliatelle.
Maledetti.
Mm.
E ti sei persa.
Eh. Ah, no, ma guarda, sono stati giorni impegnativi. Questa
Immagino.
cosa, il casino qua
Io quando ho
del-
sentito Saltatutto che stavo lì ho detto, poracciala, cosa stronza.
Ma ti rendi conto cosa avevamo fatto?
No.
Cioè, tutta la gente che mi diceva no, ma ci sono gli aerei che salgono, in effetti gli scioperi ci sono confermati, eh. Domani
Tanto mia
tutto
madre ha detto che adesso lo sciopero sarà di 4 ore,
4 ore, ho capito, ma
perché
la gente non
quello...
arrivava.
No, no, quello
Comunque,
infatti ormai è andato.
cioè,
Perché quello stronzo di Salvini ha minacciato che avrebbe fatto
sì,
delle multe stratosferiche.
sì,
Ah, Silvia, ok.
sì.
E questo però, insomma, avendo ceduto, si è creato un brutto precedente.
Ciao
Fascista.
Silvia.
Ciao Silvia.
Ascolta, Silvia, appena siamo online con il webinar, ti rimando il link, cioè è sempre lo stesso il link della pagina per lo streaming. Io l'ho già chiaramente inserito il link e appena parte io la pubblico, aggiorno la pagina così comparirà anche in diretta per loro.
Ok, grazie. Io così lo giro a Giorgia.
Mhm.
Ok. E non Giorgia, tu, ovviamente.
Immaginavo perché non...
Vi faccio vedere anche a te.
Aspetta, no, non vedo.
Sono i cremini fondenti della Novi.
E quindi
Non mi
colpa tua o
piace il
di
cremino.
Rose?
Ti piacciono i cremini, Anna?
Quelli fondenti.
Eh, no.
Ebbene sì, guardatelo, e me lo mangio. Alla facciata della Rosa che è qua di fianco, che scuote la testa, della Natalie che è qua.
Salutala.
Mina non si collega, gli ho anche mandato il messaggio.
Cremino è proprio una roba che mi piace, no. Sto coso mollaccioso, troppo cioccolatoso. Perché tu mangi solo fondente, Anna? Eh?
Sì, sì, io quello al latte, quello
Bello
bianco
sempre.
ancora meno, ma quello al latte.
Buonasera.
Ciao Roberto.
Ciao Roberto, buonasera.
Ciao, 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 ciao.
Scusa, ci stavamo discutendo di cioccolatini.
E
Ah,
al
ok.
latte,
Una
latte,
cosa
fondente.
importante.
Esatto.
Questioni prioritarie.
Cioccolato fondente al latte.
Ma per me cioccolato sempre, quindi fondente
A
al latte
prescindere.
Quindi va
proprio.
bene
Sì,
così.
sì.
Ecco,
Ok.
vedi.
Va bene tutto, va bene tutto.
Vabbè, dai, scherzi a parte, tutto bene Roberto?
Sì, tutto bene, grazie, tutto bene. Sono qui a Milano.
A Milano?
Eh, eh sì, per un meeting mi fermo qui adesso a fare la call perché farla in treno mi sembrava un po' complicato, ecco. Anche se ultimamente, devo dire, la linea sull'alta velocità Torino-Milano non è male,
Ma
però...
Torino-Milano è vero.
Dipende dalle
È
tratte.
che se devi passare da Bologna a Roma, lì è il dramma.
Un disastro.
Sì, è vero, Bologna-Roma non è un disastro,
No.
però non mi sono tanto fidato via, quindi rimango qua e spero di
Ah,
riuscire a prendere un
grazie.
treno dopo.
Ma sì, dai, ti lo auguro. Insomma, diciamo che oggi sì, domani no, ma oggi sì.
No.
No, esatto, mi è già arrivato un messaggio di ritardo, ma vabbè, il ritardo, pazienza, basta che
Dipende di
arrivi, insomma.
quanto.
Ma no, 20 minuti per ora, dai,
Mm.
Ma sì, allora dai, ancora accettabile.
ci sta, infatti.
Stavo guardando, niente, insomma, spero che l'Onianar si possa collegare in tempo utile. Ieri ha
Sì,
risposto più volte, per cui
sì,
insomma ci
no,
conto,
no,
dai.
gli mando un messaggio.
Ce l'hai il cellulare? Ah, ok.
Sì, sì.
Se tu hai il cellulare, allora vedi. Sì, scusa, certo, avete lavorato assieme, ci sta.
Allora, Voilà. Com'è andata la volta scorsa?
È andata assolutamente bene, direi, insomma. Peccato perché arrivano poche domande dai partecipanti. Io non
Stavo dicendo la
so
stessa
se è la
cosa.
lingua che mette un po' in imbarazzo. Questo è un po' sempre un dubbio che mi rimane, che tutti parlano, cioè tutti ascoltano, tutti capiscono bene, porre domande in inglese si sentono forse in
Ma sai,
imbarazzo? Non lo so.
scritte secondo me no, nel senso che alla fine in inglese scritte, se fosse un parlato sì, forse sarei più d'accordo. Non lo so se sia quello, se sia... non lo
Non
so.
lo so, i nomi delle persone iscritte sono anche nomi conosciuti, cioè tra i partecipanti vedo persone di un livello anche abbastanza alto, che probabilmente colgono anche questo evento con l'idea di mi porto a casa quello che mi ha detto senza particolare bisogno di interazione, non lo so.
Ma allora, sai, forse considera anche che comunque questi sono temi abbastanza, come dire, alti, nel senso che comunque no, cioè, tutte queste cose, questi soprattutto farmaci, e anche i dati sono un livello abbastanza alto, quindi non tutti
Sì.
hanno l'esperienza, non tutti hanno la conoscenza, e quindi poi magari fare domande non è semplicissimo,
Sì,
ecco.
perché forse c'è anche la paura di fare domande eccessivamente banali o scontate.
Esatto.
E
E poi
siccome sanno
sono
che
cose un
comunque
po'
esce il
futuristiche.
nome, e siccome sanno che esce il nome, magari uno preferisce ascoltare quello che viene riportato da altri.
Poi
Diciamo che
guarda,
comunque è stata gestita bene da te, nel senso che le domande te le eri preparate tu e quindi questo ha permesso di coprire le tempistiche necessarie. Ecco, questo è sempre un pochino l'importante in questo tipo di eventi, ecco. Sì, un po' la sensazione è quella, un po' il limite della lingua, un po' il fatto che davvero sei a confronto di persone. Allo stesso modo mi viene da dire, è un'occasione abbastanza rara di chiedere magari un qualcosa ad una persona che è difficile incontrare normalmente, però magari è anche brutta figura dietro l'angolo, insomma, non lo so, un po'
ma guarda,
tutto.
comunque anche agli eventi in presenza ti posso dire che è così, cioè, poi
Sì.
l'hai dato anche tu, cioè, non sono tanti quelli che fanno domande, che chiedono, e quindi purtroppo è sempre un po'... cioè,
Ah, guarda,
se il
sì.
format è un po' quello... o fai una roba veramente di discussione, tavola rotondo, che altrimenti diventa
Sì,
difficile.
ultimamente noi stiamo facendo veramente tante tavole rotonde a gruppi ristretti
Mm-mm.
di 12-15 persone a ferro di cavallo sedute attorno a un tavolo e allora sì, poco per volta tutti iniziano a prendere la parola, e tutti tirano fuori le cose, iniziano una discussione tra colleghi proprio, perché in quel momento si crea davvero il rapporto che tu hai magari quando fai le tue riunioni in dipartimento, ecco.
Certo.
Però quella è una realtà molto diversa da tutte queste, da quella di un evento residenziale normale dove hai tante persone, allora il livello di
Certo.
attenzione naturalmente tende un po' a scemare, tutte cose di questo tipo, insomma. Ti ha per caso risposto? No, non ancora.
Si sta collegando.
Ah, benissimo.
Grande.
Allora chiedo a Giorgia come sempre di dare il benvenuto a nome Mattioli, visto che
Poi
lei è la più brava con l'inglese.
voi vi sentite bene?
Io sì,
Sì.
benissimo. Tu hai
No,
Sì.
no.
difficoltà?
No, 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 io vi sento benissimo, è solo che giustamente qui stanno sbaraccando tutto e quindi mi chiedevo se sentiste dei rumori altri,
No.
ma oppure no.
No,
Perfetto.
no.
No, 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 no,
Ok,
no.
non avevo alternative.
No, 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 vai tranquillo, non c'è nessun problema. Poi hai messo lo sfondo sfumato, per cui nessun
Sì, sì,
problema,
sì.
anche se passa qualcuno. Abbiamo comunque sempre la regia di Alessio collegato,
Sì?
per cui nel caso ci fossero problemi tecnici, lui comunque interverrà in tempo reale. Perché
Ci
altro
sono,
anche... Sì, sì, sì.
Ok, ciao Roberto.
Ciao.
Salve Silvia. Ok, non l'avevo vista. Ok. Il relatore sta arrivando?
Sì,
Sì.
dovrebbe collegarsi
Ok.
adesso il professor Loniel e niente, attendiamo, insomma, non è
Perfetto.
un grosso problema, sono le 17 in punto in questo momento.
Sì.
Tanto non penso che abbia bisogno di particolari prove tecniche, ecco.
Ok.
Dovrebbe essere, cioè, l'unico problema, l'importante è verificare che abbia una connessione stabile.
Sì,
Quello,
ma quindi il prossimo è il 23, cioè giovedì prossimo.
Esatto,
Sì.
e lì abbiamo Bolli con la
Paola
Paola.
Neri.
Sì,
Sì.
la Paola.
Eccola.
Hello.
Good evening.
Hi, Sagar.
Hey, sorry, I was having trouble getting the link to work.
Don't worry,
No,
it's
it's
okay.
fine.
We are
Just in
time.
And then am I doing the slides from or am I using your?
You're doing it.
Okay.
Yeah. If you want to share this, the presentation to try if everything works.
Okay, hold on. And were they okay, or is there something you want me to cover more or less of?
That's perfect.
No.
If you want to just you'll do your presentation and then
Yeah.
we'll take questions from the audience. You know, people are very always shy, so I have my questions for you and to discuss. I think it will be interesting to know what you think about sequencing. So if you can stress that, what you would use first, what you think we'll use in the future and so on, but we'll have time to discuss. So take all the time you need for your presentation.
Okay, perfect. We are seeing the presentation.
Okay.
Perfect. So if you want, you can already close it so we can prepare everything for the webinar.
There's a dramatic intro, you'll see.
Oh,
like
gotcha,
last
gotcha.
year.
Okay. All right. There. Am I still sharing or am I not? I'm not, right?
You're not.
Okay, perfect. Okay. Dramatic intro.
You'll see. That's it's kind of flashy.
Possiamo partire. A questo punto chiedo al nostro tecnico di lanciare il webinar. We can start.
Perfetto,
Ok.
a dopo allora.
Ok.
Good luck.
Luck.
Good afternoon, everyone. On behalf of Motioli Health, CME provider of the event, I welcome you. This webinar, entitled 50 Minutes on Multiple Myeloma, is the second appointment of an ECM project consisting of 3 webinars. At the end of the 3 webinars, last November 2nd, today and November 23th, all learners will receive by email the instructions for completing the questionnaire and the relative satisfaction survey. The training credits assigned to this project are 4.5. We would to point out that through the questions and answers section, you will have the possibility to ask questions live at any time, and the possibility to put a like on those that you consider most interesting, in order to establish the priority of the answers. Thanks to all of you for your participation, to GSK for the non-conditioning support it provided to the project, and to Dr. Roberto Mina for the precious scientific direction of the entire project. Professor, to you the word. Good job, everyone.
Good afternoon, everyone, and good morning, Professor Lonio. So welcome to this second episode of this webinar series, 50 minutes on BCMA targeting therapies. And today we're very, very lucky to have here with us Professor Saga Lonio from the Winship Cancer Institute, Emory University, Atlanta, US. And so welcome, Professor Lonio, and thanks very much for being with us today.
Thank you.
So the topic of today is the treatment sequencing in the BCMA era. And so it will be a pleasure to discuss with you the treatment choices, the data we have, and what we should have to figure out a logical and rational sequencing in the era of BCMA agents. You know that between the FDA and EMA, we had the approval of 6 drugs in the last 3 years, 1 ADC, and then 3 T-cell engagers, 2 CAR-Ts. Those are not all available. Just to give you a background, in Italy, we had access in clinical studies to CAR-T cell. We still have access to belantamab, and we are having access. We will expect reimbursement for the TCE, teclistamab first, and elranatamab. We also had compassionate use of TALC, TEC, and ELRA. So we have tried these drugs, and I think it will be very relevant to potentially establish a sequencing between these agents, and also figure out the data we need to do this in a rational way. So please, without further ado, can you start your presentation, and we'll take questions. At the end of your presentation, we'll discuss all the evidence available. Thank you.
Thank you very much, Roberto, and I appreciate the opportunity to be here, especially in a series like this, where our goal is really to try and share some of the information we have, and then talk about controversies or perhaps approaches in terms of management of these complicated patients. So I want to start off again with setting the stage, which is the current state of the art, and that is induction is based on a 3 or 4 drug induction, depending upon availability and access. High-dose therapy and autotransplant does continue to remain a standard for fit patients. Maintenance therapy is continuous therapy, and for high-risk patients, IMiD-PI combinations continue to remain the standard. Early relapse is based on CD38-based triplet. Next relapse, again, is to switch class. If they got a PI in combination with CD38, then they would get an IMiD in next relapse. If they got the reverse, then they would get a PI in second relapse. And late relapse, again, is based upon more recent approvals. And I think one of the points we've been trying to establish with the FDA is that lines of therapy is less relevant than resistance to classes of drugs. And this is particularly important as you talk about a patient progressing on second-line therapy is potentially meeting the definition of triple-class refractory multiple myeloma. And that really represents a major challenge for us overall. Now, if you go back just a few years ago, this abstract came out in 2021, so not that long ago. What you'll see is the median progression-free, and in this context, overall survival of patients who were triple-class refractory in blue, pentaclass refractory in purple, and then a refractory myeloma from the Mammoth study. And what I think you'll see is that the median overall survival for many of these patients is somewhere between 10 and 20 months. So the options from a therapeutic perspective were ultimately really quite limited up until recently. Now, when we talk about new classes of drugs in multiple myeloma, particularly for the triple-class refractory patients, there really are 4 big categories of agents, of which in the U.S., we actually only have one of them. In the U.S., we only have selinexor available to us, which has a response rate of about 25 to 30%, with a median PFS of about 3.7 months. We don't have melflufen available in the U.S., overall response rate of about 30%, with a median PFS of 4 months. We no longer have belantamab mafodotin, as you discussed a moment ago, median PFS of 2.8 months, DOR of about 9 to 11 months. This is an ADC targeting BCMA, and we do not as yet have the new classes of CELMoDs, which are mezigdomide and iberdomide, but clearly those show promising activity in early studies. So let's start off with BCMA, because I know that that's the big focus for today's lecture, is to really talk about the role of targeting BCMA in the context of relapsed and refractory myeloma. And we know at its biological purpose, BCMA is a really important survival signal. So simply interrupting signaling through BCMA, whether it's through passive antibodies, ADCs, CAR T cells, or bispecifics, has a pro-apoptotic effect on malignant plasma cells in general. We also know that BCMA does come in a soluble form. It's created by removing BCMA from the surface of the plasma cells through an enzyme called gamma secretase, and there certainly are studies looking at gamma secretase inhibitors in combination with BCMA-directed therapy to try and improve the efficacy of these BCMA-directed therapies. And what we're going to spend the last few moments talking about really are the next few moments is really talking about bispecific antibodies, bispecific T-cell engagers, CAR T-cells, and we've got a couple of slides on antibody-drug conjugates as well. So let's start off talking about CAR T-cells. The first CAR approved in the space of relapsed and refractory multiple myeloma was ide-cel, which demonstrated very high overall response rates in a median of 5 prior lines of therapy, somewhere around 81% overall response rate, with a median PFS of somewhere around 11 to 12 months. And the higher the target cell dose, the more longer the PFS appeared to be. So this certainly was a really important first step for us in getting cellular therapy approved in the context of BCMA-directed therapy for myeloma. This was subsequently followed up by the CARTITUDE-1 study, and this is long-term follow-up of the CARTITUDE-1 study demonstrating overall response rate of about 98% in this phase 1, phase 2 clinical trial. And if you look at PFS, both by overall PFS and by MRD, what I think you'll see is that the median PFS is somewhere around 34 months for all patients, and that if you were MRD negative, we haven't reached the median with about 3-year follow-up now. And finally, if you look at overall survival, this is clearly very different than what I showed you from the Mammoth study before, demonstrating that some of these BCMA-directed therapies can be highly effective at not just getting responses, not just getting remission, but also changing the natural history of triple-class refractory multiple myeloma. Now, as we do in myeloma, if things are effective in late relapse, we start to move them into earlier relapse. And this is data from the CARTITUDE-4 study, which was a randomized phase 3 trial comparing either cilta-cel with DVD or DPD or PVD in relapsed myeloma. And I want you to look at sort of who these patients were. You can see about a third of patients in both arms had had 1 prior line of therapy, but most of them were 2 or more prior lines of therapy. And so this is an important way to differentiate certainly where this is going to come. The primary endpoint, again, was the difference in progression-free survival. And if you look at the difference here, it was about 11 months for the group that received the standard of care of either DPD or PVD. Median PFS has not been reached yet, with a median follow-up of about 18 months now in the cilta-cel group in blue. And then if you look at prior lines of therapy, because I think this is really important, if you've had 1 prior line of therapy, you were either in black or in blue. And if you were the cilta-cel, you were black is 1 prior line, blue is 2 or more prior lines of therapy. Standard of care is that dark green. So even in the 1 prior line of therapy, the black curve versus the dark green curve, pretty significant difference in progression-free survival, suggesting that even earlier in the course of disease, we are seeing significant improvements in progression-free survival. And to me, the real question is, in Len refractory patients, what do you see? This is the odds ratio favoring cilta-cel versus standard of care in terms of overall response rate, and MRD negativity at 10 to the minus 5 was 4-fold higher in the group that got cilta-cel compared to the group that got standard of care in this context. So clearly earlier is good. Whether earlier is better in terms of PFS than later, I think we need longer follow-up from CARTITUDE-4 to truly understand. And I'm hopeful it will be. I don't think we know that at this time point. At the same time, The ide-cel was doing a similar study, which was the KarMMa-3 study, looking at ide-cel versus a standard of care. And the standard of care, again, was what was available. This was a median of 3 prior lines of therapy, not the 1 to 2, as you saw from CARTITUDE-4. But I think what you'll notice is 13.3 months for ide-cel versus 4.4 months for the standard of care. So a big difference here. Again, if you look at DOR, 14.8 months versus 9.7 months. This suggests to me, again, that we are better using CAR T cells, particularly in LEN refractory patients. You can see here 2/3 of patients were in fact triple class refractory in this trial. So a little bit more heavily pretreated than the CARTITUDE-4 study that I showed you before, but clearly demonstrating there is benefit for CAR T cells over standard available therapies, even in one earlier line of therapy than what I showed you before. Now, what about the first drug that was approved in the context of BCMA-directed therapy? This is belantamab mafodotin, or Belamaf. And what you see here is that this is a monoclonal antibody that targets BCMA at the Y end, if you will, and then at the bottom end is MMAF attached as a linker. The DREAM-2 study is what led to the FDA approval and the EMEA approval of belantamab mafodotin. And that's listed here, where you can see 100% of patients were triple-class refractory, about 31% overall response rate, and the DOR in this was about 11 months. More importantly, it was the DREAM-3 study, which I don't have demonstrated here, that showed that the difference between pomalidomide and dexamethasone versus belantamab did not meet statistical difference. Now, if you look at the numeric difference, it clearly favored Belamaf. If you look at the PFS, it clearly favored Belamaf, but it did not reach the statistical hurdle that had been defined a priori for this study ahead of time. And based on that, the FDA withdrew the approval. But from what I understand, this drug is still available in Europe and is, in my mind, a viable treatment option for patients, particularly given that it's only dosed once every 3 weeks or even potentially less frequently, doesn't require hospitalization, and doesn't require a lot of supportive care in the context of weekly visits or twice-weekly visits for other issues at this time point. Now, I'm going to start the discussion on bispecific antibodies now and focus on a couple that have approved indications, and those include teclistamab in the middle and elranatamab on the left side here. But as you can see, this is a very crowded space. We've got elnuctamab, we've got elranatamab, we've got Linvo, we've got TEC, and then we've got the TNB-3838. These are all BCMA-directed therapies. On the non-BCMA, we've got talquetamab that is approved in the US, and we've got cevostamab targeting FcRH5. So 3 different targets represented on this single slide with a quick summary of response rates, durations of response, and adverse events listed here. So let's start off with the first approved BCMA T-cell engager, and that's teclistamab. This is based on the MajesTEC-1 trial. You can see here median of age of 64. Median number of prior lines was 5, and this was 165 patient experience. And what you'll see here is an overall response rate of about 63%, so 2/3 of patients will respond, and a DOR of about 21 months for all patients. And for patients who achieved a CR or better, it's almost 2 years. And what I think is really quite impressive is if you look at the CR and stringent CR, it's roughly 43% of patients here. So almost half the patients are achieving this deep, deep response that results in a DOR of about 21 months. So this to me is really important. It's really exciting. And in an area where we were sort of hoping for 20 and 30% response rates, we're seeing response rates of about 60% overall. When you look at safety, what you'll see here in terms of safety really is there's heme toxicity, which is not a surprise considering you get some level of inflammation within the bone marrow as a consequence of this T-cell engaging and cell killing. When you look at the non-heme toxicity, the 2 that really jump out at me are infections, and this is a pretty significant issue that does, I think, require aggressive prevention and prophylaxis, and we're going to touch on that in a few moments in general as well. And the second is CRS. 72% of patients will have any grade CRS, but only one patient had grade 3, grade 4. So in general, this can in fact be managed relatively easily with tocilizumab, either preemptively or with a short hospitalization for the initial treatment. What we're going to be presenting at ASH this year is a way to purely give this as an outpatient using preemptive tocilizumab. That abstract will be presented, I think, on Saturday or Sunday at ASH. Really exciting data to try and move this completely to outpatient for many patients that we know don't want to spend time in the hospital. When you look beyond that, it's not really a surprising list of adverse events here. Hypogam, especially given the efficacy and potency of this type of approach, is not a surprise either. So these are things we're going to touch on as well. But the two that, in my mind, are worth discussing are CRS and infections. So let's look at the other approved T-cell engager targeting BCMA, and that is elranatamab. And that's based on the Magnetism MM3 trial. Again, 123 patients in cohort A. What you'll see is median lines of therapy, again, was 5. Interestingly, the range was 2 to 22. Now, I treat a lot of myeloma patients. I don't know that I can come up with 22 lines of therapy, but certainly that's an impressive number, and it shows you how heavily pretreated patients were. You can see 95% were refractory to their last line of therapy, and 97% were triple-class refractory coming into this treatment. If you look at overall response rate, what you'll see is something, again, around 75% overall. A significant fraction of patients are achieving CR or SCR, almost 50%. And if you look at duration of response here, what you're seeing is that with only 15-month follow-up, about 70% of patients remain in ongoing response. And this, again, in line to what I showed you for teclistamab before, really exciting data suggesting that even in highly resistant relapse, we're seeing durable responses. If you look at, again, looking at this in terms of PFS and overall survival, compare this number here to what I showed you before in Mammoth, where the median overall survival was about 14 to 18 months. We're seeing we've not hit the median now with 18-month follow-up with elranatamab in the phase 2 study. Now, what about looking at safety here again, just to get a sense for what were the major events that we saw? Well, infections, again, continue to be an issue, and this is not a surprise. This, to me, really represents a common challenge in BCMA-directed therapy, whether it's T-cell engagers or CAR T-cells. Infection prevention and prophylaxis really is an important part of the puzzle here. And then heme toxicity, also not a surprise given that these cells live in the marrow, and we expect significant inflammation as a consequence of CRS during the initial treatment of these patients. Now, a question that Dr. Minna asked me earlier before is about sequencing. What about the data in prior exposed patients? So we don't really have that data from the KarMMa-1 study because all of these patients were BCMA naive. But if you look at patients who got ide-cel in the real world, and then look at responses for patients who had prior bispecific or ADC, you can see the response rate does drop a little bit. Not a surprise. If you look, again, cilta-cel CARTITUDE-1, nobody was BCMA exposed, but in the CARTITUDE-2 separate cohort, there were a few patients that had prior bispecifics or ADCs. And what you'll see that the response rate and PFS does, in fact, drop if they'd had prior BCMA-directed therapy. If you look at TEC and then look at retreatment with a BCMA bispecific, if you'd had a prior CAR, the response rate was lower at 53%. If you'd had a prior ADC, the response rate was lower at 55%. But the impact seems to be a little bit less here than it was for some of these others. And again, for ELRA, if you'd had prior BCMA, 55% was the overall response rate compared with 70% if you did not. So you do see a drop-off, and that may be through some mechanisms that we'll talk about in the next few moments. This is data, again, looking at the cilta-cel CARTITUDE-2 cohort. There were 18 patients that had seen prior BCMA-directed therapy. And if you look at responders versus non-responders, you can see the time from prior therapy for the non-responders was very short, only 56 days, whereas the time for the responders was almost 5 months. So the longer you are away from BCMA-directed therapy, which to me suggests that the longer the response duration is, you're more likely to respond to re-challenge of a BCMA-directed therapy. Now let's switch gears to GPRC5D, as this is a new target, and as you can see, expression on many different tumors is much lower than it is for malignant plasma cells, where the expression is significantly higher. One of the important things to recognize on GPRC5D directed therapy is that we do have bispecifics. This is Formi, which is a GPRC5D bispecifics, and you can see in early drug development from ASH 2022, the overall response rate was about 71%. If you start to look at MRD negativity, it was a high number as well. And the adverse events were similar to what you'd expect. They are slightly different for GPRC5D, however. And the reason is that GPRC5D is also expressed in the oral cavity and in the skin. And this really does differentiate GPRC5D from BCMA. And the reason I say that is if you look at talquetamab, this is the Monumental 1 study, overall response rate between weekly or every other week dosing was relatively similar. If you start to look at durations of response, it looks like perhaps it's a little better in the every other week dosing group, 11.9 months versus 7.5 months in the early phase 1 experience. DORs were actually quite good at 9.3 months and not reached for patients who achieved a CR or better. But really the difference in adverse events is what jumps out to me. First off, CRS, 79% had any grade, but only 3 patients had grade 3 or grade 4, telling me that most patients did not have CRS that required significant supportive care. A dose of tocilizumab managed most of these patients. Almost 90% were managed with supportive care alone. But what is different about GPRC5D really is skin-related adverse events, nail-related adverse events, and dysgeusia and rash. And again, most of this is grade 1, grade 2, very little grade 3, grade 4, but it is something that you have to be prepared and you have to prepare your patients for so that you can manage them during that first cycle or two to try and help them get through treatment in a way that they can continue to receive treatment over time. The skin-related typically is topical steroids, same with the rash-related. The dysgeusia may be oral steroids, like a rinse, like you might use with budesonide, for instance, as one example, or other approaches. But certainly dose holds and dose reductions and dose modifications are also strategies that you can undertake as well. This is data on the CRS, data with both the 0.4 weekly or the 0.8 given every other week. You'll see it looks slightly lower with the 0.8 given every other week. I'm not sure that this is really statistically different, but certainly CRS is an issue within the first week or so. And we are now testing that preemptive TOSI approach that I mentioned for teclistamab. We're testing that in talquetamab right now as well. And hopefully we'll have some data by ASCO or next ASH as well on this coming down the road. Now, as we highlight differences between BCMA and GPRC5D, what I want you to note is the difference in infectious complications. So you'll see that grade 3 infections are significantly higher for patients who get BCMA or BCMA plus GPRC5D combination in orange and green, whereas GPRC5D in blue is much lower incidence of infection. So what you have to be prepared for when you're managing a patient getting GPRC5D therapy is really the skin and gut-related side effects, less concerned about the infection-related effects. Whereas with BCMA, there is no skin and gut, but there is a much higher incidence of infectious complications. And of course, if it comes as a T-cell engager, it's also coming as a CAR T-cell. This is BMS 986339, or the GPRC5D-directed CAR T-cell, originally reported out of Memorial, and now BMS is doing a phase 1 study on this. You can see overall response rate, 100%. If you look at prior BCMA, 77.8%. This is coming to a phase 2 study near you, and we're very excited about having a second target for a CAR T-cell in the context of multiple myeloma. Now, as we do in myeloma, I'm not going to spend too much time on this. If they work well alone, we're going to combine them. And so this is TEC and TALC together. High overall response rate, 40% CR or better rate for both of these combinations. And you can see the responses are quick. We need longer follow-up to truly understand PFS and adverse events, but this is being tested in the context of phase 3 trials as well. Now, the last target I'm going to talk about is cevostamab. This is FCRH5 targeting BCMA, targeting bispecific. This is a third new target. So BCMA, GPRC5D, and now FCRH5. And this mechanism is similar. FCRH5 is present on malignant plasma cells. What we see with cevostamab in the early phase design was a step-up dosing to try and reduce the incidence of CRS. If you look at overall responses, what you'll see here, this is the toxicity data here, and CRS, again, is an issue, mostly grade 1, grade 2. Only one patient had grade 3 CRS. Median time to onset was within 12 hours of the first dose. This led to a step-up dose approach. The same with ICANS. Only 5 patients had grade 2 neurologic toxicity. Nobody had grade 3 neurologic toxicity at all. Relatively well managed with CRS prevention and prophylaxis. Overall response rates of about 60%, depending upon the dose that you use, and median time to first response is a month. So certainly very active, highly effective drug in this context, and is yet another new target in the context of relapsed and refractory myeloma. So as I wrap up, I want to really touch on a couple of important highlights here. The first is, why do we fail with immune therapy? Well, the first is poor T-cell health. And this has been a discussion in myeloma for a long time. When you get to 4th or 5th line therapy, how healthy are those T-cells? And I guess the argument I would put forth is, if they weren't healthy, why do we get 60 and 70% response rates with T-cell engagers? There must be some healthy T-cells there that allow us to ultimately kill myeloma cells with a T-cell engager, even in 5, 6, 7, 8, 9 prior lines of therapy. I think if CAR T-cells are going to ultimately be the cure, we're going to need either multiple infusions because the half-life is too short, or we're going to need to think about maintenance therapy for a limited duration of time on the back end. And we need to think about the immunosuppressive microenvironment to allow us to have longer durations and longer persistence for those CAR T cells. Rarely do we see antigen loss, particularly in the context of a CAR T cell. So we now have multiple targets: CD38, SLAMF7, BCMA, GPRC5D, and FCRH5. Their expression is somewhat consistent, although I will say BCMA probably has a broader representation, which is why we see more infectious complications with BCMA-directed therapy. And I think we need to understand best how to ultimately sequence and manage these patients. And so with that, I think we'll talk about getting to curative therapy with limited duration therapy, sequential or paired immune approaches, and then finally talking about precision medicine in the long term. And I left a few slides out so that we could have some time for question and answer with Dr. Mina.
Thank you, Professor Lauren. Thank you for this great presentation. And I really have a lot of questions. And meanwhile, we'll wait for people in the audience asking questions. I'd like to have your idea and opinion on this. So, you know that in an ideal setting where you have available everything, any kind of BCMA or other target, what would be your sequencing?
And so I think some of that depends on what you have as salvage therapy. So oftentimes we don't have the luxury of waiting 2 to 3 months for apheresis and then infusion and preparation of a CAR T cell. And so we have to make a decision quickly. In my mind, the likelihood of a response to a CAR after a bispecific is significantly lower than the reverse. And so I want to think about using a CAR first if I can, because I know that if a patient has an 18 or 24 or 30-month response to a CAR, then the likelihood of being able to revisit that target with a T-cell engager and having success is probably higher. And in my mind, it really gets to how we define resistance to BCMA. If a patient relapses within 6 months of coming off of a BCMA-directed therapy, that patient, in my mind, is likely BCMA refractory. We haven't set this definition, though. We as a community need to set that definition. And I would not re-challenge that patient with a BCMA-directed therapy. If, however, they relapse 18 or 24 or even longer months after a BCMA therapy, that patient may not be BCMA refractory, and I would think I would feel comfortable re-challenging that patient again. So if I've got the luxury of time, I'm going to try a CAR first, knowing that I'm more likely to be able to reuse the target later on. If I don't have the luxury of a CAR, then I'm going to use whatever I have in my pocket to get a quick response, and that may be a BCMA T-cell engager right away to try and get a quick response.
I think you touch a very important point, because we used to define refractoriness based on the resistance of a cell to a certain drug that we knew it worked, and then at some point it doesn't work anymore. But now here we have two things to consider. So is the cell resistant, or is the drug not working anymore? Like for CAR T, what is the cell that is resistant, or the CAR T that is not there, or the T cell engager as well? So I think that it was very interesting, the paper published by the Ballis group, the Olili in Nature, where they really show that there could be different mechanisms of resistance. BCMA is most of the time there, but you can have mutations where your drug doesn't bind. And I think also interesting to see that some drugs can bind different epitope. And so potentially the cell is still sensitive and sensible to that particular mechanism of action. So you could have a bispecific that doesn't work and maybe another bispecific that works. I mean, this has to be proven, but it's also, do you think this is an approach that eventually could be used also in a clinical practice, such as like in CML? So you test for a mutation, allegedly if the mutation is the same, of course, it's not a variability. Do you think it's feasible?
Yeah, so, before the Calgary group published that paper, my approach, if I was going to retreat with a BCMA-directed agent, was to do IHC for BCMA, and if expression was still there, I felt pretty good about retreating that patient. That paper totally blew that concept out of the water, because even if the expression is there, the epitope may have changed such that you can't bind it. And so now I'm thinking, how feasible is it for us to sequence BCMA if you're going to retreat? And if we lived in a world where all we had was BCMA, then we'd have to answer that question. But we don't only have BCMA now. So my thought is, if I know a patient has progressed on a BCMA-directed therapy, I'm going to switch to a different target. So GPRC5D or FCRH5, those targets are likely to be higher on my list. But I think the bigger question is, how do we avoid the development of that mutation and resistance? And in my mind, that is using it for a limited duration of therapy and then walking away. And what I think the reason we get those mutations in BCMA is constant pressure by constantly giving the drug. And particularly for patients that achieve a CR, MRD negative CR, how long do we really need to keep giving the drug? Now, you remember from your time in Atlanta, we were big proponents of continuous therapy. Keep hitting, keep hitting, keep hitting, keep hitting. I think these classes of drugs are different. And I think keep hitting only makes things worse over time. The infections are worse, the development of resistance and mutations are worse. And so we need to really think about stop therapy, and perhaps then we revisit retreatment or treatment with a different modality targeting that same receptor over time, so that you don't induce that mutation and drug resistance that Nizar's paper showed so nicely.
So Nizar's paper point out that testing for soluble BCMA is not a thing, because, I mean, it may be helpful if the soluble BCMA is not there, but then it doesn't help if it's there, because you still don't know. So if you had a patient relapsing after CAR T, like let's say 2 years after CAR T, would you try again a BCMA targeted agent, or would you just move to another target?
So right now, my answer would be I'd move to another target. And with us, we would do talquetamab. But we know that that's only going to last so long. And so in my mind, would I feel comfortable re-challenging with a BCMA-directed therapy? And the answer is yes, I would. I would, especially if it was 2 years afterwards, where I don't think that patient is BCMA resistant. But because they've had a BCMA target, switch targets, I think just makes more sense to me.
And so the reverse question is, in Europe, the belantamab came first. So we have patient exposed to a BCMA ADC. Now we do have access to TCE targeting both BCMA and GPRC5D. Would you use the same approach? So use TALC rather than trying TEC and maybe then go to TALC if it fails. Yeah, you would do that.
Yeah, I would, again, because if you don't have access to a non-BCMA target, then yes, then you use the best thing you have in your pocket. But if you do, why not go? It's like if you progress on an IMiD, why would you not think about a PI, right? I mean, so right. I think it's that same class switch mentality.
And so ideal sequencing, you said, ideally CAR-T and then like a TCE or ADC or whatever. What about target? Do you think BCMA, because BCMA came first, so we always have in the back of our mind BCMA and then everything else. Do you think it's really like this, or you can imagine GPRC5D first, or choosing based on patient characteristics? You mentioned the risk of infection, for example.
I think ultimately that may drive how we make these decisions down the road. I mean, I think we have so many potential agents in the BCMA space, it's hard not to go with BCMA first. I haven't seen a rationale for the GPRC5D before BCMA, although there is some data at ASH coming, might have a different resistance profile that I think would be worth knowing. Do you induce a different cell with GPRC5D resistance versus a BCMA resistant cell? And that's important to know because, as I said early on, BCMA is an important survival factor for myeloma. So if the cell has figured out how to become resistant to BCMA, phenotypically that may be a different cell, right? It's sort of like CD38 resistance or venetoclax resistant. Is that functionally a different type of resistance? I think in my mind right now, it's easy for me to manage infection prevention and prophylaxis. The GI and skin stuff, I think, takes a little bit more time. And so that's why I would favor BCMA earlier right now, but that may change as we get a lot more experience using GPRC5D directed therapy.
So do you have any idea why with CAR T cell, after ADC or TC, you still see very high response rates, not in the range of with cilta-cel 100%, but 60, 70%. But then the PFS is very low. So, I mean, you have some kind of cytoreduction, but then something happens. I don't know if it's a resistant one or whatever. And then the PFS is way less. So do you have any idea on this?
Yeah, that's an interesting question. And I wonder the extent to which it has something to do with simply being resistant to CAR T cell mediated mechanisms of cell death. And what I mean by that is we know that most CAR T cells work eventually through the granzyme Fas CD95 axis to kill cells. If you're resistant to chemotherapy, which is what MMAF really is, does that impair your ability to keep those cells suppressed for a longer period of time? Is it like the old P-glycoprotein story, right? Drug resistance induces other drug resistance down the road. I don't know if that's it, or if you're creating a BCMA low population that, we know, for instance, Damian Green and his group at the Hutch have shown that at day 30, the residual myeloma cells after a CAR don't lose expression of BCMA, but it's very, very low. Perhaps you're starting with a larger low population if you progress after belamaf, and that's what comes back quicker after the CAR T. They can't eliminate that BCMA low population. And that's where I think the gamma secretase inhibitors could be really important. Not giving it up front, which is the way they gave it in the Hutch study, but at day 30 or day 60 or day 100, when the CARs are still there, if you can take a low cell and make it a high cell, maybe you'll get more efficacy with that CAR at that point. That's the best I can come up with.
So we touched on the mechanisms of resistance and the issue of patients who are resistant to BCMA. You know that there are now some studies using T-cell engagers targeting BCMA either up front or like a first-line therapy induction or in this maintenance. And that is for a fixed duration. So would you be confident in using a T-cell engager in a patient that most likely won't be refractory, because you don't expect that patient to relapse on therapy or be refractory. So would you be confident in using it that way?
Yeah, I think it's a great idea. I love the idea of limited duration maintenance therapy, either post-auto or post-CAR. To me, that is really the exciting avenue to investigate. Is we know the CAR starts to wear off at about 6 months. If you went from month 6 to month 12 with the T-cell engager as maintenance, could you wipe out the remaining cells, particularly if you used a different target? That, to me, is really part of the fun of the next few years for us.
So do you think that sequencing will actually be a thing, or, as you mentioned, maybe combining, as we see the redirect study, to targets is really the way to go to prevent relapse on one side or the other side?
Yeah, it's an interesting idea, and I don't know whether giving them both at the same time or alternating 3-month stints of either is the way to go. And the reason I say that is, and we're trying to figure out how to design these experiments, if you've got a fixed pool of T cells and you now give it twice the antibody to deal with it, is it going to be any more effective than half the amount of antibody to deal with? What is the recycle time for a T cell once it's engaged with and killed a cell? How long until it can do that again? And what do you do to grow that pool as opposed to exhaust that pool? I worry if you give both together, you may have the limiting reagent may be T cells, not antibody. And so I think understanding the right way to do this, is it combination or is it sequence? Is there a role of a CELMoD in here that will wake up tired T cells? Those are all things that sort of, I think you and I get to think about and design those studies in the future.
And do you think that the combinations with CELMoDs, for example, rather than CD38, could be a thing, also could be successful? We know there are many studies now trying that in the early line.
Yeah, absolutely. That to me makes the most sense. I think you've got highly effective single agents, you put them together and they both make each other better. That to me is sort of the holy grail, I think, of where we're going to get to limited duration maintenance therapy. Now, you may have to think about timing for that, right? If you give an IMiD or a CELMoD at the same time you're starting a T-cell engager, you might get more CRS. You might get so much immune activation that it makes things worse. But if you give a month of the T-cell engager and then bring in the CELMoD or the IMiD afterwards, that makes perfect sense to me as a way to keep waking those T cells up to do their job.
Yeah, and this is what is happening in the upfront studies, where a BCMA T cell are actually will start from second cycle on, and in the maintenance setting as well. You first start lenalidomide and then you add something. So can you? And
my description of that story, which is perfect for Italy, is that in that setting, the CELMoDs are acting as the espresso or the cappuccino in the morning for the T cells.
Makes sense. So can you tell us a little bit about your experience, without spoiling the ASH data, with prophylactic dosing and the outpatient administration of bispecifics?
Yeah. So what we set up was a way where before dose 2 of the step-up dose, we would give a dose of tocilizumab. And so we did this while patients were in the hospital, because we, on label, had to hospitalize them. So we said, well, if we're there and it's a controlled environment, let's do it and see what the real data on CRS is. And the reason I said real data is if you start doing this as an outpatient and patients don't call you, then you don't really know what the incidence of fever and hypotension and all those other issues are. So this was a pretty controlled setting to allow us to do that. What we demonstrated was that with the second dose, with the preemptive dose before dose number 2, we pretty much were able to reduce the hospitalization rate afterwards, and nobody developed more, and I'm trying to remember the numbers, more than grade 1 CRS, I believe. So it made it a lot more manageable, and that 50-patient experience translated to us now a month ago, actually right before IMS, switching everybody to outpatient TAC and TALC. And so we're now validating that first 50 patients in outpatient to see how well it works, but certainly the inpatient experience gave us the comfort level that one dose of preemptive toci would get a majority of patients through without any problems.
And so we saw the data about infections with GPRC5D and BCMA, and I must say that our experience is more or less the same. Do you have the same feeling that the infection is really a big difference between the two, and that could be a way to actually differentiate between the two agents when you have to choose between it?
Yeah, infection risks is much higher with BCMA, and the challenge with the BCMA T-cell engagers is that it doesn't drop over time. With the CAR, it drops because the CAR goes away, and then you get normal immune recovery. If you're giving TEC on label at that dose forever, the risk doesn't really go away, even though patients will be in complete remission. And that's led us, for instance, to think about going to every other week and then even potentially once a month dosing to try and reduce that infection risk over time. We do know there's data from Majestic saying when you go from weekly to every other week, the infection rate is cut by 40%. So that's a step that we make for patients that achieve deep responses very quickly.
Yeah, that's our experience as well. I don't know, it's just the disease control or whatever, but we really saw a big difference when moving from every week to Q2 and Q4. So I think it's really interesting now because we are living in an area where we have patients that were treated with ADC, and some patients clearly benefit from an ADC. So it's what you mentioned about the DREAMM-3 study. It doesn't make sense to me because we never compare, for example, DARA to POM. So we never said, is DARA better than POM? And even if you say that Bela is equivalent to POM, it doesn't make any sense. So why, when you don't have POM, what are you going to do? Like you don't have another option. So we'll see the results. I think it will be very interesting to see the results with the combinations with Bela, with POM and VEL. And at some point, we may have CAR T-cell approved for double refractory patients in second line. We may have T-cell engagers with or without DARA. And we may even have belamaf combination. So I think the sequencing, it's really something that may affect a huge proportion of these patients. And I think also we really need to study and have collaborations with between universities and institutions to dissect the reasons for treatment refractoriness. Because I think that the paper by Bodies opened a door, but there are so many things that must be addressed. So are you doing anything like this in your institution? I know you work with the DAPCAR and so on. So is there anything going on?
Yeah, so anybody getting CARs or in theory T-cell engagers, when they were in the hospital, it was easier than now that they're outpatient. We're getting blood before and after to analyze for predictors by CyTOF of response. And then at resistance, we're getting blood as well, just to sort of get a sense for what does immune function look like. Was this an immune failure? Was this a mutation in the cell? What's the cause of why we're losing control of the disease over time? So that plus imaging, I think we're going to try and correlate some of that data together in a larger experience.
You do imaging to detect whether extramedullary disease could be. Yeah. And are you also looking in the bone marrow? Because to see what happens before and after.
Yeah. The before is easy. The after is always a little bit tougher. But yes, we're trying to collect that data as well.
Yeah, we're thinking about a similar experiment, trying to understand what's happening in the cell. And I think this is really key because all these drugs are very expensive. So both if the patient has to pay for insurance and if it's a national health system covering for them. So, but at the same time, they're very potent. So the optimizing these kind of treatments will be key to save money if it doesn't work and to optimize and offer another option to patients if it really works. So I think that this is a very, very interesting area of investigation. So I think that there are no more questions. So I think we can stop here. And I would really like to thank you for your availability. Thank you for this great discussion. I think it was great for everyone. And of course, thank everyone for participating today.
Good evening to everyone. I would like to say thank you to Professor Roberto Mina and Professor Sagar Lonial for sharing with us these important materials. And I would like to thanks to everybody for attending the webinar. So see you soon to the next appointment, and good evening to everybody.